Okay, which of the following is the most likely cause of the patient's findings? Aortic stenosis, hypertrophic HOCM, mitral regurg, infective endocarditis, and VSD. So we've got a 45-year-old woman with a history of IV drug use presenting to clinic with a 2-week history of shortness of breath, increasing shortness of breath and fatigue. On physical exam, she has distended neck veins and a pulsatile liver. Auscultation of her heart reveals an accentuated S1 and a high-pitched, blowing, hollow systolic murmur that increases in intensity during inspiration. The murmur is best heard at the left lower sternal border, and an echocardiogram is performed and reveals a dilation of the right atrium and the right ventricle. So we've got IV drug use. Um, and then we're looking at the left lower sternal border, which is our tricuspid, and hollow systolic during tricuspid is tricuspid regurgitation. Um, Distended neck veins usually suggest some sort of right-sided, I don't want to necessarily call it heart failure at this point, but definitely some issues there. And I mean, the distended or dilation of the right atrium and right ventricle supports that. I think combining the tricuspid regurg with IV drug use really makes me think of an infected endocarditis with Staph aureus.
Okay, final answer.
I'll go with it.
Yeah, great, beautiful, right? Tricuspid, right? Tricuspid regurgitation, right? Definitely with a lot of infectious endocarditis with drug use, right? Aortic stenosis a little bit too young, right? And it's going to be kind of on the right sternal border, right? With holosystolic hypertrophic cardiomyopathy, no family history, should be younger, right? Can get arrhythmias, mitral regurgitation, a little bit more with sore throats, strep throats that aren't paid, right? So like rheumatic fever, things like that. VSD, right? You're usually born with it. So yeah, I think you've beautifully worked through this. Good.